All right, well, I'll go ahead and get started here. I appreciate everybody joining us for the next in our series of orthopedic lectures with ValleyOrtho. Appreciate everybody jumping on and taking a little bit of time out of your evening to listen to our talk tonight. Let's see. Couple just quick housekeeping things. If you do have questions at any point during the presentation, please feel free to just go ahead and submit those. There is a question and answer tab. If you put it into that tab, so we can try to answer some of those kind of in real time during the talk. The chat box is disabled, so make sure you put it in the Q&A section. I do have a couple people helping me out tonight, trying to answer some of those questions as we're going along. Maggie Leyendecker, who's our ValleyOrtho nurse supervisor. Sarah Davis, one of our physician assistants, and Jackie Bray, one of our athletic trainers, will be kind of monitoring that question box during the talk. So if there's things that they can answer quickly as we're presenting, we'll go ahead and do that. Obviously, at the end, we'll have plenty of time to go over any other questions that are more specific to anything that I can maybe answer or that we didn't get answered during the presentation. Just briefly about myself. Again, my name is Chris George. I'm one of the orthopedic surgeons here with ValleyOrtho. I've been here with ValleyOrtho since 2015. I started my practice actually in 2013 here in private practice with Aspen Orthopedic Associates. I did my training in the Midwest. I went to University of Iowa for medical school, residency in Chicago at the University of Illinois. Then I made my way out here initially for my fellowship in sports medicine with Aspen Sports Medicine Foundation. Tonight's talk is really focused on sports medicine and arthroscopic surgery. That's one of my main specialties is sports medicine. Also do hip arthroscopy as well as joint replacements in the lower extremity, both hip and knee replacements. Quick just disclosure slide. I think this should be filled out as I don't have any financial interest in anything that I'm presenting here. I'm not paid by any company. I mentioned that not to be dramatic about it. There are some things, as we'll talk about, specific procedures or specific products a little bit later in the talk that are unique or trademarked by one company. But we classically refer to these by brand name, so I'm not trying to sell any specific product, but I did try to highlight if there's a specific company that's specific to the name of that. Again, that's not to push one brand or company more than anything else. And again, this is a lot of stuff. We'll talk about some of these techniques. This is some fairly cutting edge cartilage procedures. This talk's not meant to be exhaustive of every available cartilage surgery or cartilage technique. I'm trying to hit some of the broader topics, and we can certainly discuss things more in detail at the end if there's any questions. Brief outline of just kind of what I'm going to work through tonight. Just a few slides on anatomy and biology of normal healthy cartilage. We'll look at injury patterns in terms of acute injury to cartilage versus more chronic wear. And then the main focus of this is looking at treatment options for cartilage. Old school to new school, that I just kind of put that in there. There's some of these techniques have been around for decades and still work pretty well. Obviously, this is an area where things are advancing, on a daily or yearly basis, and so we'll highlight some of those newer, kind of a little bit more exciting options as well. I do have a specific case example on one of my patients at the end, just to highlight one of those techniques as well. So briefly, just to talk about cartilage. Most of everything we're going to talk about tonight is in relation to articular cartilage or hyaline cartilage, and that's what is in the picture here. This is just a view of a knee joint. That bright, shiny white part is the cartilage. That's ideal situation. That's perfect, pristine, healthy cartilage. That's the goal for normal cartilage function. So again, most of the talk tonight will focus on articular cartilage. Other types of cartilage, fibrocartilage, which is mostly in the connection between tendons and ligaments where that attaches down to the bone. The meniscus, which is a structure inside the knee joint, is a cartilage structure, again, fibroelastic cartilage. We also have cartilage in the trachea and growth plates. But again, we'll focus mostly on hyaline cartilage. Cartilage itself is a pretty simple structure. It's basically cells and stuff. So the cells are called chondrocytes. This is just a histologic slide over here. The little kind of white vacuole looking things and the dots, those are the actual cartilage cells. And then all the kind of purple stuff in the seam between there, that's what we call the extracellular matrix. Majority of that is water. Collagen, proteoglycans, these are all just other proteins within the cartilage. But it's in and of itself a pretty simple structure. That being said, though, it's avascular. It doesn't have any blood supply specific to the cartilage. It's aneural, no nerve endings in the cartilage, and alymphatic. So it's not connected to any other systems in our body. It's not part of our vascular or lymphatic system. That has advantages and disadvantages, as we'll highlight. Nutrition, obviously, the cartilage still needs to stay healthy and have the ability to stay as a functional living tissue. That nutrition and oxygen supply comes from the synovial fluid, or the fluid within the joint, as well as then the underlying, the deep surface of the cartilage, the subchondral bone surface, is kind of where they get nutrition from above and below. Articular cartilage, again, that Highland cartilage, pretty, again, simple function. It kind of decreases friction. It provides, essentially like ice sliding on ice in a perfect situation to where there's not friction within the joint. It also helps to distribute load more evenly across the joint surface. It's made up mostly of water. Up to 80% of cartilage is just water. And then collagen, or the main proteins that are in collagen, and that's about 10 to 15%, or up to 20%, and that's specifically type 2 collagen. Proteoglycans or the proteins make up the rest of that. And then just to highlight the different layers of cartilage, there's 3 main zones to the cartilage, and there's a kind of a cartoon drawing of it here, and then a histologic slide. But there's a superficial, an intermediate, and a deep layer. The tide mark is kind of a crucial differentiating thing between the actual cartilage itself and then the underlying bone. Injuries or damage to the cartilage that's either superficial or deep to that tide mark does have some different implications in terms of potential healing, as well as some of the different surgical options are dependent on the depth of the actual lesion or injury. Differentiating between cartilage injury versus cartilage wear. So in injury, and that's what we're going to focus most of the rest of this talk on, is actual cartilage injury. And that's an acute disruption of the cartilage surface. Can be from an acute injury, it can be, most of the time we're talking about a specific injury with that, and that actually causes a disruption in the cartilage surface. It could be a large piece of cartilage that gets knocked off. It could be just a crack or a fissure in the cartilage. That does lead to cell death, though. So the cartilage begins to necrose in that focal area, not the entire joint surface becoming completely worn out, but that focal area, the cells start to die. Secondary to that, there's a release of inflammatory cytokines, inflammatory proteins, which can further contribute to damage of that articular cartilage. The end result of that, not in the first hours or days, but down the road, years downward, is post-traumatic arthritis, where that process may become more diffuse throughout the joint. And that's differentiated from cartilage wear, which is more of a degenerative process. Arthritis is the classic example of that. There's a whole bunch of different examples of what those wear things could be: adhesion, abrasion, transfer. But to show what that looks like, kind of to differentiate that, the picture on the left of the screen, this is more what we see with an acute cartilage injury. The bright white is the cartilage. You can see how that's disrupted down to the bone surface here in the middle. There's some fraying of the cartilage. You see these cracks or fissures in it. Versus what we see in the setting of arthritis or cartilage wear, it's much more diffuse kind of wear, not a focal injury as we see by contrast on the left. So can cartilage heal? The short answer is not great. Superficial injuries, and again, this is kind of where that tide mark comes through in the layers of cartilage, as we talked about. Injuries in the superficial cartilage that are above that tide mark, the cartilage cells can heal. They might proliferate, but they don't really. The cartilage cells can proliferate, but there's not really any healing because there's no blood flow to allow that healing process to occur. Injuries that go through that tide mark, if it affects that subchondral bone, can have some healing potential. There's stem cells, mesenchymal stem cells that are in our bone marrow that then can float into the joint or into that area of injury and basically forms a scar cartilage. We refer to it as fibrocartilage, and that's type 1 collagen versus type 2 collagen. Type 2 is the normal Highland cartilage, so it's not exactly Highland cartilage. It's better than nothing, but it is more prone to wear and is less resilient for the long term. So kind of transitioning to treatment options. There are some situations where an acute injury may knock off a huge or large piece of cartilage where the next step is immediately the surgery. That's rarely the case. And we can oftentimes start with non-operative options. And pausing on a second for that, the initial workup, if someone comes in and has an injury and we're suspicious of cartilage injury, that may be apparent by physical exam if they have some catching or locking in the knee. X-rays, we don't see the cartilage, so that may not be that helpful. MRI is probably the most helpful in seeing the actual cartilage itself, as well as potential disruption or loose pieces of cartilage. Treatment-wise, getting back to that, first line is kind of the standard RICE, rest, elevation, compression. PT can be helpful sometimes working on getting strength and function back in the tissues around the joint. Bracing to try to offload the area can sometimes be helpful. Injections, there's a variety of options for injections. Steroid, viscosupplementation, which is a cartilage protein or the gel injections. There are some biologic injections, PRP, stem cell, things like that. They can certainly help with symptoms, or all these things can help with symptoms. The healing of that injury or defect is pretty unlikely in that situation, though. Moving past just the non-operative or conservative options, looking at how do we treat a cartilage injury, or how do we decide what we're going to do? There's no universal algorithm. We don't go down stepwise, one step after another. There's a lot of variability to this, and it's a lot to do with patient and injury factors. Before we get to treating cartilage damage or cartilage injury, it is important to consider other anatomic issues. If there's malalignment or someone has, a deformity to the joint, in looking at the knee kind of specifically in this ligament injuries or ligament instability, if there's a meniscus tear, those things have to be addressed in addition to this. If we ignore other mechanical factors to the joint, the long-term outcome or even short-term outcome of a cartilage procedure is certainly going to be limited. And one of those deciding factors is the size of the lesion. And kind of still classically is about 2 centimeters square. So a 2 centimeter square lesion kind of differentiates into, there are some options that work better for smaller lesions and some that work better for larger lesions. A little bit more specifically, when we're looking at surgery for cartilage injuries, again, this is very individualized to the patient as well as to the injury. And there's a whole bunch of factors that play into this. Again, kind of grouped between factors specific to the defect or the cartilage injury part, and then patient factors. So defect or injury factor, size, as we talked about, location. If this is in a weight-bearing or non-weight-bearing location, that may have different implications in terms of repair options, or if it even needs repair. Contained versus uncontained. And that means, is that lesion surrounded by other cartilage? If it goes all the way to the edge of the bone and there's not an edge to that, there are some of these options that we'll talk about don't work as well as others. And then depth of injury is important. If that just goes through the superficial layers of cartilage versus down to the bone, we need to consider how much do we need to fix or replace just cartilage, or do we need to include the bone below that? Patient factors, in addition, age is important. Younger patients heal better. If someone already has fairly significant arthritis or cartilage wear and then has another injury, we may not need to be looking at these more aggressive cartilage options versus treating symptoms. Activity level of the patient is important. And then a lot of these procedures have a fairly extended rehab protocol. So if someone just doesn't have time or doesn't have the ability to tolerate, several months or even up to a year of rehab back to full activity, that needs to be taken into account in that decision process. Kind of starting at almost the most simple, or kind of the old school option in terms of cartilage surgery would be just a simple debridement, or we call it chondroplasty. So kind of cleaning up that cartilage damage. This is an arthroscopic surgery. We're removing or smoothing out the loose or torn flaps of the cartilage. It actually helps to stabilize the edges of that so it doesn't continue to progress. It can have a very immediate effect in terms of minimizing or relieving mechanical symptoms, catching, locking, popping, things like that. Surgery is pretty quick, 30 to 40-minute arthroscopic procedure, and a fairly quick rehab back to full activity. Short term, great results. 50-70% of people have returned to almost normal function. Very unpredictable for the long term. Some of those patients may say, my knee feels great, or whatever the joint it is feels great for the long term. People say, yeah, it felt really good for a few weeks, but now I'm starting to notice symptoms again. Just an example of that, these are some arthroscopic pictures. On the left side here, this is a loose piece of cartilage that's just floating in the joint. That's something that can be resected out or removed out fairly easily. Flaps are kind of tears to the cartilage here on the right side of the screen. And then basically what we're doing to show the result of that here, we can clean that up or kind of smooth things out. Arthroscopically, we do have a magnified view. I know this looks kind of like a roughened surface still, but this is much better tolerated for the knee and less symptomatic or painful compared to all these frayed edges or loose flaps floating around inside the joint. And then kind of, I still group this in the old school side of things, microfracture, and that may be the thing that most people are familiar with in terms of cartilage surgery. And not saying that it's not a good option, but microfracture is what we call a marrow stimulation technique. What we're doing basically is cleaning up that lesion or cleaning up that defect, and then poking some holes into the bone, essentially. So we're going through that tide mark and connecting the joint or that superficial surface to the underlying bone marrow. That allows our marrow cells or stem cells to float into that defect, and it forms some scar cartilage. So it doesn't form true articular Highland cartilage, but filling in that pothole is better than having a defect. Small areas or small lesions that are contained or have walls to it do the best with this. This is for the best results, it's a very strict surgical protocol in terms of preparing the area and doing the actual microfracture, as well as a fairly strict rehab protocol. The first 6 weeks is completely non-weight bearing, so that there's not pressure squeezing those new cells out of there. Over years, this procedure probably got overused, where resurgents would say, oh, here's a small area, some cartilage, where let's poke some holes in that, but not really change things from a rehab standpoint. And so that's not the optimal situation. Does this still work? Sure, but we have some other options or other adjuncts to even make microfracture more successful, which we'll highlight coming up here. This is just to show an example of microfracture. The picture on the top left here, this is showing that area of cartilage damage right here. Preparing I keep talking about preparing the bed, preparing the area. We want to clean out all those loose or torn flaps of cartilage. You want to have nice kind of flush edges to the cartilage around there. Then this is showing the middle picture, so you're poking those little holes during that microfracture, where we're kind of poking through that tide mark or the calcified cartilage layer, which then as we turn off the flow arthroscopically, you can see that blood flow coming out of the bone into that area. So this is what a microfracture looks like surgically. The rest of the talk will kind of focus more on the kind of some of the newer, kind of, I think, more exciting topics with this. And there's kind of 3 different parts to this. Analogous to the recycling algorithm, we reduce, reuse, recycle. We can repair cartilage, we can replace cartilage, or we're starting to be able to more reliably regenerate cartilage. And we'll kind of talk through each of those in specifics. Repair, I don't have a lot of other slides on this. There are some situations where with an acute injury, it knocks off a piece of cartilage with bone underneath there. If we can get to that acutely in a matter of the first few days or weeks, that can be potentially fixed, just like you would fix a fracture by securing that back down to the bone. That is restoring normal, healthy articular cartilage right to that defect. That's pretty rare that we're in that situation. Replacing the cartilage, so actually putting in a cartilage graft, does replace it with true Highland cartilage. That's the only other way that we can replace normal articular cartilage. The regenerative options are Highland-like, so it's close to normal cartilage, but not exactly normal cartilage. In general, and this I kind of alluded to earlier with some of the talk about microfracture, for cartilage surgery, there's kind of a general workflow in terms of the steps of the surgery. First is preparing the area, and this is the same whether we're able to do something arthroscopically or open. Some of these techniques are an arthroscopic application. Some have to be done as an open surgery. But you're going to prepare that area. That's cleaning up the torn cartilage, any other work that needs to be done, meniscus, things like that. And I tried to mention this earlier. Most of this discussion is about the knee specifically. A lot of these techniques were developed in the knee. work best outcome-wise within the knee joint. There's certainly applications in other joints, shoulders, ankles, hips, but the majority of this is fairly specific to the knee. So cleaning up the area and then establishing distinct borders of the lesion. We want to have nice edges to it to contain that defect. That's going to allow the cartilage to basically grow or regenerate flush with the surrounding tissue. We want to then prepare the bed. Again, where that graft is going to go, whether that's just the cartilage surface, whether that's bone, we need to prepare that, whether that includes microfracture, bone grafting, any other stuff that needs to be done, and then applying or implanting the graft. What I have right there is sealing that as needed. Depending on what it is, some of these have a seal to that, others are just a graft going into the bone. Replacement. So how can we replace normal articular cartilage? The two main options for that, one is called an Oates procedure, which is osteochondral allograft transplant, or an allograft transplant. And to difference between those, which sounds somewhat similar, autograft means that we're using the patient's own tissue. We're using their tissue from inside their knee or whatever joint we're working on, versus an allograft, which is a cadaver or a donor tissue. Similar concept with an ACL or things like that. Autograft ACL is using a patient's own tissue versus a cadaver tissue. So for the Oates, or the autograft Oates, what we're basically doing is taking a plug of cartilage with some underlying bone from one part of the knee and putting it into that defect. So we're taking a little bone and cartilage and plugging it back into the area of damage. That is replacing, again, true articular cartilage. The cartilage cells that are on that graft remain live and remain viable cells as that plug heals into position. Nice things about this procedure, it's one-stage surgery. Some of the other things that we'll talk about require more than one procedure. It can be done arthroscopically in its autologous tissue. Downsides, it is a size limitation. We are taking cartilage away from somewhere else, and it may not generate a flush surface. Just to show what that looks like, here's kind of showing we're taking a plug of cartilage from one spot, transferring it to another location. That can be a single plug versus multiple plugs, or what's called a mosaicplasty. This is what that looks like clinically. This is a mosaicplasty. You can see we filled in a defect here with these little plugs. It's better than having a big pothole here, but it's not perfectly flush and congruent with the surrounding tissue. Another kind of newer innovation to that, or newer option, I should say, is an allograft, or a donor plug. These are pre-cut, so we're not harvesting a plug. There's no donor site damage to that, but it does still have living cartilage cells in that. So kind of an extension of not having to take cartilage from somewhere else inside the joint. The allograft version of this, or what's called osteochondral allograft transplantation, similar concept. We're replacing cartilage and bone, but from a cadaver graft. This is a fresh graft. Once that graft is available, we have about 7 to 10 days to implant that. Not quite the same time scale as a kidney transplant or things like that, but we are a little bit more time limited to maintain living, healthy cartilage cells. Nice things about this is it can address a larger area. We can fill in a big defect with one single graft. We can make it deeper too if we need to address underlying bone loss. This does better match the curvature of normal articular cartilage. Downsides, we do have to wait for a graft to be available, a little bit higher cost compared to using someone's own tissue. There's a theoretical infection risk. I say theoretical, it is a graft. These are sterile grafts. There have not been any reported cases of disease transmission from a cartilage or soft tissue graft. Again, to show what that looks like schematically, here's that area of lesion on the femur. And this is one single kind of large plug to fill in that defect. What that looks like in a real surgical situation, here's that defect within the joint. You can see that damaged cartilage with normal cartilage above and around that. This is the donor femur. We match that. The nice thing is we're taking this plug from the same area of damage. So it's going to match that contour of the bone very precisely. Here's preparing that bone, preparing the bed down here, and then implanting that graft into position. This is press fit into the bone, so it's wedged tightly into the bone. We don't have to fix it with screws or anything else like that. We can also, as I mentioned, cover larger areas. You can stack grafts. We kind of refer to this as a snowman graft. We can put two of these right next to each other. Arthrex, one of the surgical companies, has what's called a bio-uni, which is on the right side here, which allows us to make a much bigger kind of oval shaped graft to cover a larger area. regenerative options. So that's how we can replace the cartilage. Is it possible to regenerate cartilage? Our body, like I said, doesn't regenerate cartilage in and of itself, but can we help that process along? And there are some options that accomplish that. Autograft, again, there are ways of using our own cells to do that. There are allograft or donor or cadaver cells. Synthetic, I have over here still with a question mark. We're not at the point where there's a viable synthetic option that replaces cartilage at this point. Down the road, that may be a different discussion. And just to highlight one last thing, Highland Light. So this is where we're generating Highland Light cartilage. To look at, this is a study that was published several years ago in our sports medicine journal. True Highland cartilage, if you look at the stiffness of that, is about 3 newtons. Fibrocartilage, or that healing cartilage that we see with microfracture, things like that, is about half of that, or just less than half, 1.3 or 1.27 newtons. Highland Light cartilage comes in at about 2.7 or 2.8. That's much closer to normal Highland cartilage, so that's the goal. If we're trying to regenerate cartilage, we want to be as close to normal Highland cartilage as we can. The main option for that from an autologous or the patient's own cells is what's called an ACI, or autologous chondrocyte implantation. This is a true cell therapy. It's a 2-stage surgery. So the first stage is an arthroscopic surgery, clean up that area. They actually then harvest or biopsy some cartilage cells that are then sent to some specific labs. They harvest the cartilage cells out of that piece of cartilage that we send, and then grow those and expand them in culture. Those are then sent back in a second surgery, which is done open. That area is prepared. A patch, usually periosteum or bone lining, is sewed onto the lesion. And then those cells, those cartilage cells, are injected underneath. This does regenerate normal Highland Light but autologous tissue. This can be sized to fit whatever defect there is. In terms of positives, downsides, it is 2 surgeries. It has to be contained. And this is probably, out of any of the options, the longest rehab. This can be up to 1 year, maybe even longer, back to full and unrestricted activity. To show what that looks like here, here's the kind of schematic version of that. You can see that plug here injecting the cells underneath there. This is what it looks like in a real situation. The little stitches that we see here, that's sewing that patch on there, and then the cells are injected underneath that. We then seal over top of that with some glue or fibrin glue that keeps that intact. MACI, or matrix associated ACI, is kind of the next version of this, or ACI 2.0. Those cells, instead of just coming that we inject underneath, are actually implanted onto a scaffold. We can then put that scaffold into the defect. So this can potentially be done arthroscopically for smaller lesions. Still a 2-stage procedure, still just as long recovery-wise. And then a couple just things to highlight in terms of the options we have for allograft tissue. In terms of using cadaver or cells or things that we have on the shelf to address a defect in real time. These are some of the things that are specific kind of brand name. Again, not trying to market one versus the other, but just to highlight some of these. De novo is an option for that. And this is actually they're juvenile living cartilage cells. This is how it comes. It's in a little vial of viable cartilage cells. To show what we can prepare that defect, nice edges to that, it's contained, and then those cells are basically injected or kind of pasted into that lesion, sealed again with a fibrin glue to keep that in place. This again forms Highland Light cartilage, a mix of type 1 and type 2 cartilage. Very similar or analogous to biocartilage. This is not living cartilage cells, but it has dehydrated cartilage cells in there as well as normal cartilage matrix. Basic principle is the same, but this is kind of I would call this the microfracture 2.0. We prepare that lesion, microfracture it, so stem cells or bone marrow cells are going to drift out, but then we're putting those other cartilage cells in that defect, sealing that down with some fibrin glue, so it signals an autologous pathway. So, version of microfracture combined with some more advanced kind of cell signaling and scaffolding techniques. This is what that looks like in a real situation. Here's the lesion again, nice prepared bed to that, showing the microfracture here with the bleeding bone, and then that the biocartilage injected into that area and sealed with some fibrin glue. This again can be done arthroscopically, which is a nice advantage of this. This is a slide I took from another colleague's talk that this is at the time of surgery. This was done open. But here, what I'm kind of outlining here, that's that area where the biocartilage was. It's sealed with that glue. I don't remember the exact situation, but they did have to go back into the knee about 2.5 to 3 weeks after surgery for a separate issue. But looking here, you can see that it's starting to get some bleeding and maturation of that, but that's all contained, staying right within that defect. And the last thing to kind of highlight within this regenerative pathway is something called Cartiform. And this is kind of an off-the-shelf version of that osteochondral allograft. It's a sheet basically it's a flexible kind of disc that comes in different shapes. You can cut this to size, but there's two surfaces to it. This kind of cross-sectional view. This the outer surface of it has cartilage cells on that. The deep surface that's in contact with the bone has some bone cells in it. This is anchored down or fixed into the bone with bone anchors and suture, but this covers that defect. Here's a couple of clinical pictures. Again, we can cut that exactly to size, and this provides a nice bed for cartilage healing and cartilage regeneration. Just to kind of put some of this together and show an example of a case of mine. This is a 33-year-old male. He had about 2 years of worsening knee pain on the medial side of his knee. Got worse with bending and squatting, clicking, catching, did have those mechanical symptoms. About 10 years ago, did have a meniscus tear and subsequent repair, but not having meniscus type symptoms at the time that we saw his patient. Couple of views of his MRI here. This is kind of what we call sagittal or side view. Here's the femur up top, tibia is down below here. The black is the bone. The lighter gray that I'm kind of tracing with the arrow, that's the cartilage. And you can see here, there's this gap or defect here in the cartilage. Bright white is fluid in the knee joint, but here's this space where there's not cartilage there. Same view or we're just looking at it here from the front view. Here's that area where we're missing that cartilage. Meniscus is the triangles on the sides there, which looks great. So not another issue that we need to address. We did look at this initially arthroscopically. Here's that defect. And so kind of this more oblong or oval shape here that when we kind of probe that, you can see this is just looking at it from a different angle, kind of goes all the way down to the bone. This is a full thickness cartilage defect. What we ended up doing was that a bio-uni, or the osteochondral allograft. And these are pictures from the surgery. This is that area of the defect. You can see where it looks darker here. That's that cartilage damage all the way down to the bone here in these areas. Normal, healthy cartilage surrounding that, though. This is as we've prepared the bone here. Nice bed ready for that graft to come into. Here's that donor graft again, a cadaver graft with fresh graft with living cartilage cells in there. And then the technique in terms of highlighting out where we're harvesting this again right from that same area, so that contour is going to match really nicely. Here's that prepared graft in our sizing guide essentially, and then here's that graft impacted into position. So we've covered that entire defect with the knee. This is kind of a unique case because we do have some follow-up on this. Unfortunately, about 2.5 years after the surgery, he did have a separate injury to the knee. We did not suspicious that this was the same cartilage injury, but we do have a new MRI. You can see at about 2.5 years, this is where that plug, the cartilage and bone, is right here. But compared to that first MRI, nice, normal, healthy-looking cartilage underneath it. So pretty smooth contour of the cartilage. We did end up doing another arthroscopic surgery on his knee to address his other problem, but we can see here, this is the back or the posterior part of the graft. You can see where that line is here, but that's fully integrated, looks just like the surrounding healthy cartilage there. Nice, even, flush appearance to that. This is the anterior, the leading edge. Part of what we needed to do, we had some fragmentation of the cartilage adjacent to that, but you can see how that's healed and incorporated fully into the bone underneath there. Nice, flush appearance past that. So excellent outcome from that cartilage replacement procedure in this case. So just to kind of summarize things, and I'm happy to kind of take some time and talk through more specifics or answer any other questions, but cartilage injuries are a big deal. It can be a significant cause of joint dysfunction and pain, mostly due to the fact that there's not really any potential for healing. Corollary to this, not what we addressed in this talk, but same thing with arthritis. Once cartilage is worn out, more in a diffuse setting, we don't have a way to reverse or regenerate that process, especially diffusely. So even a small crack or small injury can cause pretty significant issues because there's just no healing potential. Treatment, again, very individualized to the patient as well as to the defect. Many times, again, we'll start very conservatively, just cleaning this up arthroscopically. If that doesn't get the patient to where they need to be functionally, looking at some of those more advanced or aggressive surgical options. And again, there's no one size fits all. There's no one procedure fits all in this situation. Depth, location, individual variation, it really plays into that decision process. And I think this is one of those things when I'm talking to a patient about potentially doing surgery for a cartilage injury. This is something this is not a quick 5-minute discussion. This is looking at what are their goals, what's the rehab going to be, what's going to give the best outcome for the long term. These replacement or regenerative surgeries that we talked about do have a pretty long rehabilitation course. Not where people are completely shut down, but it is something to consider. This is not a 2 or 3 week thing and back to full activity. 3 to 6 months, kind of at minimum for some of those back to full activity, potentially even up to a year before unrestricted activity to allow that cartilage and bone to fully heal from the injury and surgery. That being said, yes, it's long recovery, but outcomes, especially at mid to long-term follow-up, are very good. So choosing the right surgery, choosing the right patient is important, but we do see very good outcomes in terms of keeping the joint very functional for the long term. That's kind of the conclusion of what I had prepared. I'm happy to answer more questions. Before we get to that, I do just want to make a quick plug. What I have up on the screen here is kind of the upcoming next talks in our series with my partners, Dr. Potter, Dr. Leota, Dr. Griot, Dr. Mahan, and Dr. Armstrong. We do have an addition to this that I think we're excited to share with you. We are adding some lectures a little bit more specific to physical therapy, athletic training, and the rehab side of things. These will be hosted by some of our physical therapists at Valley View. The first of these will actually be coming up on July 21st, so in about a month. That's in what we're trying to address in the previous couple talks that we've had. There's been some questions that come up that are a little bit more specific to the physical therapy or to the rehab side of things. And we've compiled those. We'll address some of those specific questions and then expand on things from the rehab standpoint. The first session again on July 21st. If you've signed up for these before, you'll get an invitation or a reminder to that. That first session though is going to be a little bit more focused on the knee, but then we'll also have sessions on shoulder, hips, other joints, and things like that. So appreciate everybody logging on and listening here. I'll pause here for a second, and I'm certainly happy to stick around and answer any other questions.
Thank you, Dr. George. This is Maggie. That was great. I think Jackie, Sarah, and I all learned a little something from your talk. We do have a couple questions for you. The first question, just wondering about what the risk is or chances for failure or rejection of some of these cartilage repairs, and what you would do as a next step in that case.
Yeah, and that's a great question. And there's kind of 2 different ways I answer that. In terms of rejection, that's pretty low likelihood. And that's, I say that from the immune system standpoint. So different than, and not to give a dramatically different example, but a kidney transplant, for example, which is hooked into the blood system or hooked into our circulatory system and the immune system. There's a risk of rejection in that situation where the body just says something doesn't match up immunologically, it's not getting the right blood flow. That's not what we're not in that situation with cartilage surgery. Again, it doesn't have its own blood supply. It's not a part of the immune system. So in a true or kind of classic rejection situation, we don't see that. Is there failures? Of course. I think, again, choosing the right surgery based on the lesion, and a lot of this is if we're not addressing the full depth of the lesion, if that injury goes down to the bone, but we're just putting a surface treatment to that, increased risk or probably that increases that risk of failure. There are these surgeries are not exclusive or mutually exclusive. If we do one, it doesn't mean that we don't have another option. So not that we try to do things in a stepwise fashion and say this is going to be multiple surgeries, but if we try a microfracture, for example, and it doesn't work, that doesn't mean we couldn't still do a cartilage graft, the allograft, or a cartilage transplant, or some of the other surface techniques. So there are some options that work better after a potential failed first surgery. I think the other way to look at this too is oftentimes we're doing some of these more advanced or aggressive procedures in younger patients. It's probably not a solution for the rest of their life. In this patient, the example or case example I went through before, this guy's in his mid-30s now. This should hopefully last another 10, 15, 20 years, hopefully longer. If things wear out and he's in his late 40s or 50s, knee replacements or partial knee replacements are a much more durable or reliable option at that point. So again, that's more of an individualized thing. But in terms of rejection, we don't really see that since it's not a part of the immune system. So it's not something where all of a sudden things just fall out or the graft doesn't take. But there can certainly be things where it just doesn't heal or it doesn't heal flush, and then we're either looking at an alternative option or potentially a salvage option farther down the road.
Great. We had another question come in about the use of glucosamine. If you think that that's effective, ineffective, or unknown.
Yeah. So glucosamine, and there's glucosamine chondroitin sulfate is a supplement. Chondroitin sulfate is one of those proteins that we talked about being the proteoglycans and things that make up normal cartilage. That's one of the most abundant proteins in cartilage. So that is a very common joint supplement that people take. There's not really any data at this point that shows that either keeps cartilage healthy or minimizes injury or damage to cartilage. There's certainly nothing that shows that it actually regenerates cartilage. And that being said, there are plenty of times where plenty of patients say, I've been taking glucosamine, or I started this, and my knee or my hip or my shoulder feels way better. We don't 100% understand the mechanism for that. What I could reliably say is that it's not going to rebuild or regenerate cartilage. If it helps symptomatically, or if it helps from a functional standpoint, there's no downside to that. There's not one there are certainly different options or different brands of that. There's juices, there's powders, there's pills. If one works for you, that's the best one to use. And not that everything has to be proven or shown with some study to work for it to be effective. But what I talk to patients about with that is it's probably worth trying. Any supplement, cartilage supplement, joint supplement, health supplement, they're not regulated by the FDA. And that I don't love everything the FDA does. I don't mean that as a negative. That just means that there might be 2 or 3 different brands on the shelf next to each other that have a slightly different dosing. Take it as it's directed. I think most important is it doesn't work like a pain medicine. It's not like ibuprofen or something like that where you take it and it feels better in a couple hours. It may be a couple weeks or even a month of taking that and then kind of stepping back and saying, is this helping me? If it is, they're very safe to take for the long term. If you've been taking it for a few months and say, yeah, I don't think it's really doing anything, there's probably other things to spend your money on.
Well, so we had a couple of people interested in injections. You briefly mentioned injections as a non-operative option. Wondering about the value of stem cells and PRP as treatment.
Yeah, and that's an emerging area or an area where I think that may move up the list of ways that we're treating cartilage injury or cartilage damage. I didn't mean to just gloss right over that. We have some other talks coming up that are a little bit more specific on injections. But in this situation with cartilage, again, kind of 3 main types of injections. A steroid injection, or often we call it cortisone injection, that's an anti-inflammatory medicine. It helps with pain. It helps to calm things down within the joint. Nice thing is it works very quickly to calm down pain. Excuse me. Downside is it's very variable in terms of how long it lasts. Some patients, they say, man, I felt better for several months. But people say it felt amazing for a couple of days, but then wore off. The gel injections are more specific for knee arthritis. I'm going to glance over that one at this point. Biologic injections, stem cells, PRP, things like that. There's certainly some promise to that. It's certainly an exciting option to say, hey, can I get an injection and solve this versus having to go through surgery and a 6 to 12 month recovery. To highlight because some of the specific PRP, which stands for platelet-rich plasma, that's from blood, platelets from our blood. So we draw a patient's blood, spin that in a centrifuge to isolate the platelets, then we inject those platelets either into the joint or it can be done in soft tissue. The goal of that is to generate a healing response. So platelets help our blood to clot. They also are one of the first cells that gets to an area of injury. So they do have a lot of growth factors on them that help to start the healing process. So it can, the best data we have right now for PRP injections is with soft tissue, partial tendon tears, chronic tendonitis, or things like that. That can actually kind of reverse that course and stimulate that tendon to heal. That's kind of the gold standard for PRP. Some newer studies have just come out with PRP and arthritis. In that situation, they're equivalent to and maybe trending a little bit better in terms of pain relief compared to steroid or compared to the gel injections. The data at this point on cartilage injury, especially a focal or a localized cartilage injury, is okay, not any better than any other option. Stem cells, by contrast, so stem cell is a very generalized vague term for what's a little bit more specific term would be a mesenchymal stromal cell. Not to be overly scientific, not my area of expertise by any means, but meaning that the basis of a stem cell injection, a stem cell can become anything. It can become bone, it can become muscle, it can become an organ. If we put stem cells inside of a joint, all we know at this point is that we put stem cells inside of a joint. I'm not anti-stem cells. I don't want to come up that way at all, but we don't have a way to direct that to say, go to this lesion or become cartilage cells once it's inside the joint. And so in terms of harvesting stem cells, where do we get those? There are some autologous or some graft options. The highest concentration of stem cells is either doing a bone marrow harvest, or you can get them from fat cells or lipid cells. The outcomes at this point again are okay but not great. So I don't think it's a bad option. I certainly don't feel comfortable telling a patient now, whether that's arthritis or whether it's a focal cartilage injury, that PRP or stem cells are going to be a reliable solution. I think there's a lot of promise with that. I think hopefully in the not too distant future, I think the next leap that we need to make in terms of the science of it is, once we get those cells inside the joint, whether that's an injection, whether that's a surgical application, is how do we get them to go to the right spot, or how do we induce that to become cartilage versus just there's stem cells inside the joint. The downside potentially of some of those options too, of the biologic injections, stem cells, PRP, insurance companies at this point consider it experimental, so they're not covered by insurance. We certainly do those. We do PRP injections in the office for certain situations. Stem cells, I'm not doing routinely just because the cost. I can't confidently say, yeah, it's going to be a couple $1,000s for this injection. It might help. So I don't think they're bad. I think we're going to see more and more of that into the future. I think that's going to hopefully be the next big revolution in terms of cartilage and arthritis treatment. At this point, they can certainly be helpful, but I wouldn't consider it a solution, especially for the situations that we were kind of talking about in this discussion.
Great. Well, I think that we will wrap things up at this point. Thank you again, Dr. George, for your presentation.
Thank you.
And thank you to all of our participants for tuning in.